Hello, my name is Stephen Lewis. I'm an oncologist from Bristol. I'm going to talk to you about the way in which drugs are handled by the body, pharmacokinetics. It's a subject that really doesn't interest an awful lot of people, but it's quite central to the way we treat patients with cancer, and pharmacokinetics I think is at least important for you to understand in principle. I don't think you need to worry about some of the more complex equations, but there are a few points that it might be worth paying attention to. So, firstly, we're going to talk about what is pharmacokinetics, or what are pharmacokinetics, and it's normally defined as the mathematics of the time course of absorption, distribution, metabolism and excretion of drugs in the body. So it's trying to build models to describe what you observe with regard to concentrations of drugs after they've been given to a patient. And the factors that affect this are biological, the way your body behaves, physiological, the way in which your blood circulates around your body, the way in which you absorb things from your gut, physicochemical, which are to do with properties of the drug or the preparation of the drug, for example. All of those things which influence the transfer processes of drugs in the body also influence the rate and extent of the absorption, distribution, metabolism and elimination of those drugs from the body. So pharmacokinetics, what the patient does to the drug. Here's a simple model that's sometimes used to describe the way in which drugs are handled in the body. And in the bottom left we've got this little graph which shows a concentration against time for a drug taken. In this example I'm going to give you for a drug given by mouth. So if we first imagine that you're giving a patient a drug, the concentration in your gut rises, and then it's absorbed from the gut into the central compartment, which for simplicity's sake we'll call the central blood volume. Then from there the drug distributes around the body to what we call a peripheral compartment, and that's everywhere, but it's behaving function as if it's just a big bag into which the drug can diffuse. And it diffuses passively or actively, but it's in this case we're going to think about it being distributed in a passive manner. And you'll see that having risen, in the bottom left hand corner here, having risen, the concentration in the blood starts to level off, and that corresponds to the distribution phase between the central compartment and the peripheral compartment. As the concentration rises in the peripheral compartment, so you get more return of drug to the central compartment, and of course as the concentration rises in the peripheral compartment you get elimination of the drug. So unless more drug's being given on top, you find that the concentration falls gradually and your concentration in the central compartment gradually tails away, and that gives you this nice rise and falling curve that should be quite familiar to most of you. So really all we're trying to do with a pharmacokinetic analysis is trying to model that process. You can create much more complicated models. You can choose central compartments with multiple peripheral compartments, and people have done this to really quite complex degrees. There's very little value in any of this. It doesn't correlate with anything useful. It gives mathematicians things to think about. So that's not going to happen here. This is quite important though, and it's something which I'm sure you're all familiar with, but needs to be specifically thought about. You give somebody a concentration of a drug, it rises, a dose of a drug, the concentration rises, and then gradually falls away and would disappear to zero over time. If you give a second dose before the first drug is gone, then of course you get another rise, and this time the second peak rises to a higher value than previously. And again, the curve continues down, and so on if you give multiple doses. And what you see is a stepwise march, an increase in concentration, so that you approach a steady state concentration after about 3 or 4 doses, and that's consistent. Okay, so you get a steady state concentration after about 3 or 4 doses. If you're monitoring drug levels, therefore, it makes sense to do your monitoring after 3 or 4 doses of the drug. There are ways of calculating many of these parameters. I'm not going to go into the equations at the moment. It is worthwhile at least understanding how they're made. The other thing to think about here, just to be aware of, is the dosing frequency influences the concentration that you're getting to. So, mathematical models being used to represent all or part of the body, and the real question you have to ask is, does it fit the data, and does it predict subsequent data, and are these models useful? Can they allow you to design the right way to dose somebody, if it should be 6 hourly or 12 hourly or every 3 days or whatever? Can you individualize therapy so it works more effectively? So, pharmacokinetics, the effects of an individual on the drug. The flip side, of course, is pharmacodynamics, which is the effect of a drug on the individual. So what you're looking at here is really the normal effects that you see. So change in blood pressure if you give an antihypertensive, change in blood glucose if you give insulin or a hypoglycemic drug, but also in oncology, tumour response or toxicity of the patient, which may not happen straight away. And there's a relationship between kinetics and dynamics, and that link is clearly, you would expect to be reasonably close. Drug response depends on the quantity of drug fixed to sites of action. So that can be receptors, that can be catecholamine receptors in muscle preparations, for example, but it can be intracellular receptors, it can be triggers of apoptosis, it can be intracellular proteins or enzymes, or even DNA itself. They're functionally acting as receptors. And there often is a very close relationship between pharmacokinetics and binding to those particular membrane receptors. And then you may find a relationship between enzyme inhibition and concentration, for example, or binding and response, or concentration of drugs and response, but you can't always show it. And you may not be able to find what you want to show, which is, if I give this much drug, I get this much effect. Here's an example, simple example, using warfarin. Warfarin inhibits protein synthesis by the liver. There's also a parallel process with slow degradation of protein occurring in the body as coagulant factors are used up. So both of those processes lead to a reduction in clotting factors, and that leads to an overall anticoagulatory effect. If you look at the end point of what warfarin does, which is inhibit protein synthesis, then there actually is a very close correlation between the concentration of warfarin and the inhibition of protein synthesis. But what you're interested in is how much anticoagulation you get, and actually there's a very poor concentration to effect relationship. So in this case, monitoring levels of warfarin is pretty useless. What you really want to do is to monitor how much anticoagulation you get, so that you end up with the right end result. The third word beginning with pharmaco is pharmacogenetics, and that's a relatively recent specialty. Pharmacogenetics refers to the influence of your genome on the way in which drugs are handled, usually. And here's an example which we're quite familiar with in leukemia management. So this is thiopurine methyltransferase activity. Thiopurine methyltransferase being a detoxifying enzyme for thiopurines. And what you, I hope, are aware of is that for the majority of people there's relatively high TPMT activity, and so you get fairly predictable responses. You give so much drug and so much of it is detoxified, and you get a reasonable level of toxicity. There's a smallish proportion who are heterozygotes, who have a relatively low but still not a dangerously low activity, and about 1 in 300 of patients end up with double homozygote negative TPMT, so a low function of the TPMT gene enzyme, which means that if you give them a small dose of 6-MP, they get a significant myeloablation very quickly, and it goes on for a long time. There are other examples which we can talk about separately. Next concept that it's important to think about whenever you're thinking about the way drugs are handled is this thing called the therapeutic index. And I'm sorry if I'm going over stuff that you learnt in medical school, but the number of doctors that I come across who can't really work out what I'm talking about when we talk about things like therapeutic index is quite high. Therapeutic index. For an individual patient, you could describe it as, for example, the ratio of a dose which gives you an unacceptable toxicity, or at least at which it appears, to that at which a therapeutic effect is seen. Or it could be the ratio of exposure causing that toxicity to the exposure causing a particular activity. You can define it in lots of ways. You can define it in terms of dose or concentration or duration, But the commodity that we tend to deal in most is this thing called the AUC, the area under the concentration time curve, which is something which acts as a surrogate endpoint for quite a lot of pharmacokinetic studies. So here's a sort of graphical illustration of therapeutic index, and it's just really to show you how the therapeutic index depends on not only on the characteristics of the drugs, but also what you consider to be an acceptable toxicity. These are data from a particular paper that was published quite a while ago using a drug called teniposide, which is like etoposide. And what it shows is that if you take a particular exposure to a drug in terms of, it could be dose, it could be AUC, whatever, then you find that as the exposure increases, so you get more toxicity, but your response rises also. And these rise roughly in parallel. And one way of defining your therapeutic index might be to say this dose here, or this exposure here, and divide it by this dose here. So you have a ratio B divided by A, which is your therapeutic index, and that's a perfectly acceptable way of looking at the situation, especially in a population. But of course, if you're prepared to accept much higher toxicity, supposing this is neutropenia, and in fact you're prepared to allow everybody to become neutropenic, then actually it doesn't matter that they all get that toxicity, and so your therapeutic index for this particular toxicity is greater than it would be for another toxicity. If this was acute death, then you'd be looking further down here. In fact, you wouldn't accept it at all, so the therapeutic index with regard to that would be 0. Okay, so that's the end of that little sort of introductory phase. I'll stop here and move on to a second part of the talk in the second podcast.